Well, thank you for having me, everyone. I'm really glad I get to see you. I'm also glad that we get to have a lot of conversation and after the presentation. I have I've been at Karen just about 19 years, and I've worked in a lot of different capacities between being a therapist and a clinical supervisor. I worked in admissions early on, and just I love treatment. I love watching people become better versions of themselves from whatever it is that they're struggling with. And marijuana is obviously something that is prevalent, something we need to be talking about. I've had really good conversations with Paul. I got to see Eric last week up on campus. So there's going to be a couple pieces of this presentation that I wanted to keep in here, yet not spend a ton of time on. Because from what I understand, you guys have had the honor of getting lots of great presentations around marijuana. And I don't want to have a ton of repeat for you. So some of the things that I want to focus on over the next half an hour or so, I want to give you a little bit of information about facts and stats, just so that you have them. Again, not something I'm going to spend a ton of time on. I also want to talk about treatment and recovery factors. So what is it that we're seeing in treatment as far as marijuana addiction, cannabis use kind of overall, and some of the treatment trends that we're seeing. And then I'm always a big fan of not just talking about the problem, but really talking about the solution. So I also want to talk about, as family members, as treatment providers, as interventionists, what can we do? What are some of the things that are kind of within our control? And here's the thing. I've been spending time in and around treatment for a long time, and there are so many things that I don't know. So my hope is that I can give you some different ways to look at things, maybe some tools. And like many things, take what you want and leave the rest. I'm hoping that some of this can kind of hit home for you. So just to kind of get us started, what cannabis is, what it isn't. There's a lot that we can talk about here and focus on here. I don't want to spend a whole lot of time on a lot of the logistics of cannabis. When we look at THC, that's the problem, right? So that's the piece that is the psychoactive chemical that is mood and mind altering. Then we start thinking about CBD, but THC is really, when you think about the addictive components of marijuana, THC is really where it's at. I'm not going to spend a whole lot of time talking about different methods of use and what things look like. But the potency is one of the reasons why we are struggling as a society as much as we are, and as families as much as we are. So when we think about THC and the impact that it has on the brain, part of the reason why we see the symptoms that we do is because it impacts a lot of different areas of the brain. So when we think about movement, judgment, why people make poor decisions while under the influence, talking about that reward center. So why is it that people continue to use despite consequences? Because of the impact that it really has on the limbic system. Again, I think a lot of these things, from what I understand from Paul and Eric, you guys have been around long enough that you know those things, and many of you experience them kind of in your life with your loved ones. But I really appreciate the visual of really looking at what are the areas of the brain that does impact, so that when we look at what are the barriers that get in the way of people getting better, and also what do we see in treatment and early recovery, the visual of this kind of helps some of the other aspects make a little bit more sense. Because the truth is, when we look at people who are using consistently for a longer duration over a longer period of time and higher potency, we know that there's an impact on memory. So the way that we go about treatment is going to have to be different, and the expectations that we have in early recovery are going to have to be a little bit different. So again, I don't want to focus a whole lot on methods of consumption, but what I want to point to is potency factors, right? You guys have been hearing for a long time that a big reason why we're struggling the way we are is because of the potency. So when you look at flower marijuana, you're talking about potency maybe somewhere around 17%. I did hear from Paul that recently the Connecticut Assembly actually passed some bills that really look at the importance of improving warning labels, but also banning some pieces around THC potency in gummies. So when we look at eaten use and edibles, we all know that the way that they're packaged is there's a lot of concerns and issues around that I think our society is trying to wrap our arms around. When we start looking at vaped marijuana, then we start looking at really significant potency. And what we're going to talk about is the impact that has on our loved ones and different individuals. There's a lot of resources and research in the back of this presentation. Again, I'll make sure that Paula has a copy of it so that if you want to read up more on kind of current stats and current research, one of the pieces that is really helpful, Smart Approaches to Marijuana, if you've not been on their website, it's pretty fantastic. What they really talk about is when you look at the potency of marijuana, or what they call Woodstock weed, kind of back in the 70s, what we're looking at today is just, that's not it. What we're actually looking at today is really the comparison of, a 20-ounce Coca-Cola versus 33 16-ounce cappuccinos, right? So if we look at it, we can look at a lot of stats and look at it a lot of numbers, but the truth is, this is what we're dealing with. So when we look at the tendency for addiction to happen a lot quicker, we understand why. When we look at daily activities of daily living being significantly impacted, we understand why. When we look at our loved ones kind of crashing and burning a lot quicker than they have in decades past, we can start kind of understanding why a little bit quicker. So I am sure that you've had a whole lot of research in front of you. The two pieces that I really want to focus on just for a moment, just because these came out within the past probably 2 months or so and are really significant. So there's this belief that a full-blown cannabis use disorder, that's the piece that comes with issues, right? With adverse psychosocial events. So psychosocial events is really your ability to navigate socially, your ability to maintain relationships, your ability for emotional kind of stability and regulation. All of those elements we think of being impacted by a severe cannabis use disorder. And a more recent research really looked at the fact that non-disordered cannabis use amongst adolescents is associated with adverse psychosocial events. So when we look at some of the impacts that adolescents are having when they're using cannabis, but not to a point where it actually really is characterized as a use disorder, they're still having adverse psychosocial events. So when we talk about this minimization of recreational use, a lot of the research studies that are newer are really talking about the fact that you don't need to have a full-blown cannabis use disorder for it to have adverse effects. So research is showing some of the things that we are seeing and really starting to back that. Non-cannabis use disorders are 4 times more common than cannabis use disorders, specifically in adolescents. So again, when we look at this piece, many adolescents, when they're using, they may not get to the point just yet where we're looking at a full-blown cannabis use disorder, but they're still having issues as a result of it. And what you'll find is when we talk about what is, quote, kind of disordered, what makes it a problem? And I had a conversation, I was up in Manhattan about 2 months ago with a lot of clinicians and talking specifically about cannabis. And one of the things that we were talking about was the fact that as an industry, we're really looking at cannabis comparable to alcohol. Alcohol isn't an issue. What happens to us when we consume alcohol in ways that are abusive, or when we have kind of predetermined factors that set us up for alcoholism, that's the problem, right? Because we all know people who can have a glass of wine once a month, once a week, and they have no adverse effects. There is the capability of being able to smoke marijuana once a month and not having adverse effects. But what ends up happening is the higher the potency, the more of a chance of somebody to have an actual use disorder. Very comparable to the use of liquor in high consumptions versus maybe a 4% beer. So when you look at that potency, there's a lot of comparisons between cannabis and alcohol. So when we look from a mental health standpoint, at what makes it actually disordered, what we look at is that a mild use disorder accounts for 2 or 3 of these symptoms. A moderate use disorder accounts for 4 to 5, and 6 symptoms or above really characterize it as a severe use disorder. So again, when we go back to this research study, what it really indicates is that non-disordered cannabis use, so people who are using cannabis that aren't necessarily having all of these symptoms, are still having issues in their life, are still having adverse psychosocial events. So what ends up happening is the more they use, the more consequences they have. It's becoming disordered a lot quicker, right? So the other thing that I want to talk about is same study. Teenagers who use cannabis only recreationally are still 2 to 4 times more likely to develop psychiatric disorders. So when we look at cannabis, many times we hear things like, well, I don't use it all the time, right? Well, I only use it with friends. Well, I'm only using it 2 to 3 times a week, whatever recreationally looks like. And when we really look at some of these pieces, we know through a lot of studies that cannabis use on a regular, consistent basis makes every psychiatric malady actually worse. There's a lot of studies over a long period of time that really look at that. So when we look at some of the more recent studies, one of the things that's really important to talk about is you don't have to have a full-blown disorder to have a lot of these consequences, to set yourself up to develop psychiatric disorders, to set yourself up to have adverse psychosocial events. So those are the things that when we start to hear, but it's not that bad, the truth is there's a lot that even comes along with cannabis use that isn't diagnosable yet. The other piece that I want to talk about, this is another study. This was done, I believe, last month, maybe the month before, study that was really geared towards young men and knowing that they're at the highest risk for schizophrenia linked with cannabis use disorder. So one of the things that we see in treatment when we're looking at really treating young adults is there are times when a thought disorder or what looks like a thought disorder kind of comes to the surface. And the amount of times that that's coupled with cannabis use is pretty significant. So if you're on the front lines and really looking at the patients that are coming into treatment that are struggling with a cannabis use disorder, thought disorders in young adults is pretty prevalent. Now, there's some people that they have symptoms of a thought disorder, but it's not a full-blown thought disorder. They put down the chemical, they get back to a regulation, and they're able to continue on with their lives. And some people, even when they put the chemical down, the symptoms of thought disorders kind of continue and persist, resulting in full-blown schizophrenia. So again, when we look at these pieces, the message really needs to be, here are the risks that go along with it. And I want you to know that if you are going to use it, be an informed consumer, right? Be an informed consumer. And we'll talk about kind of the messaging in just a little bit. So clinical factors, what are we seeing at Karen? Surprisingly, the percentage of people coming in over the past couple of years identifying marijuana as a primary drug of choice is pretty flush across the board. Now, this is our fiscal year. So if I gave this presentation next month, I would have some 2023 results. And when we look at some of these pieces, and Paul and I went back and forth on this a little bit, this is based on self-report, right? So when people are coming into treatment and we're asking them, if you had to identify the primary issue that you have, what would that be? How do they identify the primary issue? Now, what we haven't gone back and looked at is when we do a psychosocial assessment, that's really where we're getting some of that information. But then if we compare that to a urine drug screen, sometimes people come in saying, I don't use marijuana because they just assume that it's out of their system at this point. But their drug screen and their body kind of tells a different story. So I'll be interested to see how the percentages increase. But when we look at people who are using, what we're seeing is a significant increase in a lot of these areas. So when it comes to addiction, I think we can call it denial we can call it, protective cognitions. It's kind of the way I think about it, where I protect myself from kind of believing what the reality is. So I tell myself that if I use marijuana as a replacement for a harder drug, that's not as bad, right? And we've had a lot of family members who come in and say, so-and-so used to struggle with opiates and pain medication. He's just smoking marijuana at this time. And so when we look at some of those elements, the language around it can very much still be that language of marijuana being a gateway drug. And one of the things that, as you look at an increase in potency, there's a lot of concern with continuing to think about it as a gateway drug, because it implies that it's not bad in and of itself. And the higher the potency, the worse it actually is. So we see people with significant psychosocial issues, significant issues with being able to manage their day-to-day life, and significant symptoms from marijuana. They don't need to use marijuana to get to something worse. Marijuana is their worse. So again, something to think about. Explanation, a reticence to disclose use. So it's a lot easier maybe to talk about alcohol because they may be ready to give that up. They may be ready to give up the opiates that they didn't have a prescription for, and that's what's gotten them into trouble at work. But they have a medical marijuana card and they're not really ready to give that piece up. So what happens is they may be more reticent to disclose use. So sometimes we actually hear about it for the first time from the referent or from the family member, and not necessarily from the patient. There was a patient that we had recently that was an older adult patient, and they talked about their alcohol use significantly in treatment, and the family members continued to say, ask them about their marijuana use. And the importance of really following up on that throughout treatment, because the plan for that individual was, I know alcohol is a problem. I have no desire to stop smoking marijuana. So when you look at some of those factors, there's the readiness to change can be different based on what the chemical is. We also see people on one side of the spectrum, they're kind of reticent to disclose their use, but the other side of the spectrum, they can be staunchly defended with facts, right? So when you look at all of the information that's out there on the internet that really, when we look at all the information that's out there on the internet, there's a lot of misinformation that really talks about what marijuana does or doesn't do for people. So when we look at the amount of people that come in with medical marijuana cards, really looking at the relationship with that card is one of the things that we try to do clinically, because that card in and of itself can feel really powerful. It can feel like a security blanket for people. The other thing that's a misconception is withdrawal. There's this belief that marijuana isn't physically addictive. So how is it that you have withdrawal symptoms? And the truth is you do. When we look at rebound anxiety and irritability, anger, aggression, all of those pieces come as a result of my brain has gotten used to regular marijuana use, and now my body's trying to figure out what to do without it. And the truth is, there's a lot of people that come in using marijuana because they're just looking for relief. They're just looking for relief. And we'll talk about really what that looks like. So I'm going to skip through some of this. When we talk about marijuana withdrawal syndrome, this is a piece that, again, we see pretty frequently in treatment. We do a lot of education on what post-acute withdrawal symptom is, and the differences in symptoms based on the chemicals that are being used. I think some people believe that if I just put down a chemical, I'm going to physically feel better and I'll just continue on with life. The body and the brain doesn't really respond that way. Sometimes we need to hit a reset button that takes a little bit of time. So when we look at repeated marijuana use, we look at withdrawal syndrome. And here are some of the symptoms that come along with it. Now, post-acute withdrawal symptoms can last up to 24 months. So depending on what and how much you're using, the symptoms of post-acute withdrawal can last for a pretty long time. And a piece of that is because when we look at post-acute withdrawal, we understand it as a biopsychosocial issue. So from a biological standpoint, we acknowledge the damage that's done to the central nervous system. From a psychological standpoint, it's going to be really important for them to be able to look at managing stress. because post-acute withdrawal symptoms are worsened by stress. And the more stressed I get, the more post-acute withdrawal symptoms I get. The more post-acute withdrawal symptoms I get, the more stressed I am. So it ends up having this reciprocal effect. And then really looking at environmental stressors. So thinking about what to expect, I really like this graph. I use this a lot with patients and with families because I think it helps kind of set expectation that when someone comes into treatment, if you start with the graph all the way on the left-hand side, think about that baseline as like that normal state. And some people are born just 2 steps below what normal is, right? Because they struggle with the amount of dopamine they have. They chemically just may be a little bit off. And what happens is when I use, it feels really good. And I want that relief again from whatever it is. You could fill in that blank in so many ways. And when I come back down, I don't feel as good as I did on that baseline. So I use again to try to feel a little bit better. And it's just not as good as it was the first time. So then I get to the point where I'm using just to kind of feel normal, right? And this equates to marijuana use for sure. And then by the time I get to treatment, this is kind of where I start. Sometimes we as family members, sometimes we as patients believe that if I stop using, I'm going to end up a baseline. But the truth is in early recovery, it takes a lot of practice and sometimes just time for the brain to be able to repair. So this is really what early recovery looks like. I'm going to skip over this. So types of post-acute withdrawal symptoms. This is what it looks like. It's going to look a little bit different based on the chemical. But the truth is when we look at the DSM-5 criteria for a substance use disorder specific to cannabis, all of these pieces are true. So when we talk about craving and inability to think clearly and memory problems is actually worse with marijuana than it is with a lot of other substances. And is worsened even when you're using marijuana for a shorter period of time. Emotional overreaction or numbness. If we look at people who use marijuana to try to positively impact depressive or anxiety related symptoms, as they're using creates almost like this numbness so that when they stop, it's almost like taking the top off of a pressure cooker. If you're not in a position to be able to let the pressure out bit by bit with good coping skills, the top just kind of busts off. So when we talk about this overreaction that we see sometimes coming off of the chemical and in early recovery, it's really a post-acute withdrawal symptom. It's not them trying to be mean or being unappreciative. It's their nervous system being able to kind of re-regulate without the chemical in it. So one of the things that we very much look at is we can easily look at a cannabis use disorder and look at all of the issues with it, right? All of the problems, all of the consequences. And we do a lot of that in treatment. The other piece that's really important to look at is what are they getting out of it? What's the payoff for them? Because if I only focus on the consequences, I never get a chance to flip the coin. Right? I never get a chance to help them look at what are some of those other things. Because the truth is, they're using marijuana for a reason. I want to understand what those reasons are, because those exact reasons why they use it are going to be the exact reasons why they want to go back to it. So if I'm struggling with sleep and I'm using marijuana to be able to manage my sleep issues, just because I get off of marijuana doesn't mean that the sleep issues are going to get any better. I need to actively really think about what are the coping skills that are put into place to help them with some of these things. I don't know that we always do a good job of holding space for this, holding space for the being curious about, well, what's in it for you? What's the payoff? Not just the consequence, what's the payoff? So really focusing on that piece, I think, is really an important part of helping people start with their journey. I'm going to skip over a few of these pieces. So when we look at highlighting risk and protective factors, when we look at the dimensions and we look at it from a lens of readiness to change, cognitive conditions, from a clinical standpoint, this is kind of how we look at next level of care recommendations. This is how we look at symptom reduction in the midst of treatment, and also what are the strengths that people have and how to really leverage them. We also look at risk and protective factors. So when we look at some risk factors, are we looking at people who are seeking a sensation? They want to feel something different than how they feel when they're on no chemicals at all. And it's interesting because you can actually see this from younger ages. Paul and I were just talking prior to us starting here, and he was asking me about my kids. My kids are ages 20, 13, 3, and 1. The struggle's real. But when we look at when I look at them developmentally, really thinking about when kids are seeking some sort of sensation and looking for something outside of themselves to make their feelings different, or to self-soothe, I think it makes sense developmentally up to a certain point. But when we are in a position where we're looking outside of ourselves for things like that, it's very easy to eventually replace that with a mood and mind altering chemical. Because if we already did it with food, if we're already doing it with relationships, if we're already doing it with other sensation seeking behavior, why wouldn't a chemical do that, right? So when we look at some of these risk factors, again, the opposite side of the coin is, how do we take some of these risk factors and help flip the coin to make them into protective factors? What does that look like? There's this belief that as people get older, this gets harder. I don't think it gets harder. I think that the way that we go about doing it changes. So again, I don't want to spend a ton of time on this, but I just want to make sure you have it in front of you. We also know that starting use at a younger age puts people at a much higher risk. I've heard people talk about, not telling your kids, no, don't do it, but more of a message of like, hold off as long as you can. So when you think about drinking, if you think about trying to, play around with chemicals, here are all the risks that come along with it. Also, maybe you have a genetic predisposition, and it's important to say, like, this runs in your family. So when you look at Johnny, he has a much lower risk to become addicted to cannabis because of his genetics versus really looking at your genetics. So hold off as long as you can and ask yourself, why are you using it, right? What environmental factors are in place that make you want to use it? Are we looking at peer pressure? Are we looking at difficulty in, being able to express emotions? Are we looking at all of the hormones that come along with adolescent and young adults, right? So thinking about some of those pieces. Psychological factors, there's a lot of research and studies around ACEs, adverse childhood experiences, that when we look at psychological factors, we think about trauma, a level of anxiety or depression, heightened or lowered, right? We also think about resilience factors. So when we factor in psychological predeterminants, one of the things that we really think about is, what's your level of resilience? Because the higher my level of resilience is, the less likely I am to look at a chemical for relief. Again, risk factors, protective factors in a little bit of a different way. All right, so when we start thinking about how do we support change, right? If we have a loved one who's really struggling with marijuana use right now because it's where they are, because they are in recovery from something else and have relapsed on marijuana, because they have something else going on that they're trying to use marijuana to treat or to reduce. How do we support change? I can tell you from a clinical standpoint, some of the treatment considerations that we think about is making sure that we're doing a full assessment, right? So we're not just asking about the cannabis use, we're asking about all the things around it. So being curious about the why, not just the how. The other thing that we really think about is contingency management. We know contingency management works in a lot of ways. And when we think about contingency management, it's really looking at increasing motivation based on incentives, right? So how do I reinforce the positive changes where somebody may be taking steps in the right direction? They may not be completely clean, but how are they making progress in the right direction? And are we finding positive reinforcement around some of those pieces to help continue them along? We also know research shows motivational interviewing is one of the best methods when it comes to factors in helping to support people in cannabis use disorder. We're going to talk about that a little bit more from a family perspective. Education is important. And I know a lot of people that they have the facts and they do it anyway, right? So I think education is incredibly important. And if someone is entrenched in the midst of an active addiction, it's only going to take them so far. And it's important to plant seeds. I can tell you, I've had times where I've had conversations with my 20-year-old where a lot of it is planting seeds. There may not be change in that moment, but I know that if I plant it, eventually he will think about it. Eventually, hopefully when he needs it, he's going to be able to pull that knowledge out or maybe even the skills out. The other thing is when I think about adolescents, well, that's not true. Adolescents, young adults, and adults, we need skills, right? We need skills to manage emotions. We need skills to talk about difficult things. We need resources. So when I think about treatment considerations, I know another factor is really looking at what are the skills that are being put into place to really help people move along. So we talk about this concept of a spirit of MI, a spirit of motivational interviewing. Because we know that collaboration works a lot better than confrontation. We know evoking and trying to get people to talk works a lot better than imposing ideas. We know that autonomy works a lot better than authority. And I also know that as parents, when we're afraid, it's a lot easier for me to fall back into confronting, imposing, and using authority. So much easier, because in fear, there's a part of us that wants to control. Even if we intellectually know better, there's a part of us that goes back into that. As clinicians, we do the same thing. As clinicians, when we become afraid or we feel like we hit a wall, there are times when we want to confront instead of collaborate. So many times when it comes to family members, we talk a lot about really evoking this spirit of motivational interviewing. So there's a lot of efficacy in motivational interviewing. I can tell you that in being at Karen 19 years, the way I was initially clinically trained was I will tell you all of the reasons why use is so bad and how you may die from this. And I'm going to try to instill fear in you. And it got people scared, but it didn't always get them to change. And that's what treatment did 20 years ago, right? And if we look at really using motivational interviewing to help people look at what could their lives be, how could they be different? What does it look like moving forward? So when we think about the principles of MI, we think about expressing empathy, supporting self-efficacy. Now, this is a really hard one, because if we have somebody living in our home who's using and they're struggling on their own to really make choices that are different than using on a regular basis, supporting self-efficacy can be challenging. And we'll talk about in a minute what that looks like. Rolling with resistance. It can be so easy to hit people kind of head on rather than sidestepping it. So when someone is really in the midst of provoking strong emotions in you, how do you sidestep that and really roll with the resistance? And then also developing discrepancies. I hear you talk about wanting to go back to school, and I'm watching you not actually enroll. I hear you talking about wanting to get this job, but I watch you continuing to smoke marijuana, knowing that you get drug tested to try to get it. So really holding a mirror up to what are the goals that you talk about having, and how have the behaviors not really aligned with that? So we talk about this idea of darn cat, right? Darn really looks at a desire. So how, as family members, what's within our control to increase their desire to want to change? What's within our control to help them see their ability to? People get clean from marijuana all the time. People put cannabis use disorders into remission all the time. When we look at the ability to really utilize and leverage different pieces, the ability to really look at, well, no, you can do something different. I've watched you change. These are the things that I've seen you do. What's their reason? What's their why? And then do they have the need? And we'll talk about this piece in just a minute. Again, implementing change talk, darn cat. The cat piece is the most predictive of positive outcomes. So do they have a commitment? How do we activate that commitment? And then how do we help support them in taking steps? So here are some things that, I just want to kind of put in front of you as some resources. I'm a big fan of journaling. It's one of those things that people may struggle with at times, but being able to kind of write out some of these pieces might be helpful for you. There's this AID rule, allowing, inspiring, demonstrating. I'm going to have a hard time expecting you to change unless I'm walking the walk, demonstrated by you guys being here today. When do I know to refer and ask for help? How do I untie myself emotionally from the outcome? What does that look like? And then some of these other pieces. So when I think about boundaries, and I'll leave this with you guys, when I think about boundaries, one of the things to really think about and go back to are really looking at what are your core values. At the core, what makes me who I am? What are the things that are incredibly important to me? What are those fundamental beliefs? And then what are the examples of boundaries that really help support those core values? So I have in here some examples of what that might look like. I would really encourage you guys over the next probably couple of days, really think about what are your core values and what does that mean for you? What do I need and how do I honor those core values? So here are some examples here. If I value peace, here are the things I need to do to keep peace in my life and what gets in the way of that. Boundaries happen over a continuum. We have to ask ourselves, what's too much, what's too little, and what's just right? When I don't take care of myself, I go to too much and try to control. I go to too little and I feel completely powerless and I struggle with the just right. So part of self-care is actually really just showing up here and being able to have this conversation. So what I have here are a bunch of resources. If you're somebody who likes research, I have a lot of references here specific to marijuana and specific to some of the boundaries work that I have in this presentation for you. So I want to respect time. I think I went about 34 minutes, and I actually want to stop there and open it up to some discussion. Let me stop sharing my screen.
Thanks, Kate. That was great.
Sorry, I'm trying to stop sharing my screen. Just give me a second. Maybe I'm not going to stop sharing my screen.
No, you're good.
No, you're good.
Right
It's fun.
now.
Yeah.
So, did somebody, you had a hand raised, Jennifer, I think. Go ahead.
Thank you. I appreciate that. So, talking about stages of change as a parent, when you have a young adult who is very resistant to change, what can you do as a parent aside from holding firm boundaries? But what can you do as a parent, or what would you recommend for parents whose children are not at the point where they recognize that, and they're fairly high achieving, they're working, they're going to school, they're getting decent grades, they're meeting adequate expectations. But as a parent, you see the future. So what are your recommendations at that point?
Yeah, that's a great question. So for you, when you say you could see the future, can you talk a little bit more about that, Jennifer?
Yeah, I worry about consumption of high potency THC, and it getting in the way, where it's being used as a lubricant for social anxiety, for anxiety and depression. And where I would say the brain is really dysregulated, and continuing along that, and continuing, I would gather, not being well regulated, and not being well regulated, and not really being willing to seek alternative support for like anxiety and depression. Did I say that clearly?
Yeah.
I feel
No,
like
you said that incredibly clearly.
Okay.
And I appreciate you talking through that, because I think the examples of it are really important. So what's interesting is you talk about, we can talk about people that just can't function. They're down and out. They can't hold a job. They can't get to school. They can't maintain relationships. That one's a little bit easier to see and for other people to see. But when you have people that are high achieving, it's like, but look at all that I'm doing. What's the problem? What's the problem? And you use the word adequate, right? It's just enough. And I think being able to talk through that is really important because the question I think of frequently is, are you happy, right? Are you happy? And do you know like what happiness looks like and what it is? Are you happy today? And if you continue on the path that you are today, could you imagine yourself being happy and fulfilled 5 and 10 years from now? And it's a question that I think comes up. I would also ask that if they're a young adult and they're looking at having a lasting, fulfilling relationship, it's sometimes really hard to have a chemical as a primary relationship, but also invite someone else in to have a relationship with you. So then all of a sudden, the things that you would use a significant other for, right? So like we may hang out with our significant others because we are bored, because we want to have a good time, because it's Tuesday, because it's raining, because we want to celebrate, because we had a really hard day. But if I go to cannabis for those things, I may not be in a position where I ever feel like I need to go to a significant other for that. And if that happens over a longer period of time, if they're at the point where they ever want to have kids, would they change? Would they choose to change what they're doing when they invite children into their life? So like thinking about, I think sometimes having those conversations, not in a forceful, like we have to have this conversation way, but to be able to implant some of those things kind of along the way of, yeah, like it's adequate. It's all adequate. And are you okay with adequate, right? If you're okay with adequate, like, okay, but at least call it just adequate. Because when I look at you as your parent, I see all of the things that you do, and then I see this space of all of the other things. I get chills thinking about it. I think of all of those other things. And I envision you this way. I envision you this way. But if you continue to do the things that you're doing, how does that get in the way, get you closer to or further away from like who you really want to be? Like having some of those conversations. But I also think that when you talk about that, the stages of change, and I passed through that slide really quickly. When we think about people that are pre-contemplative, I don't have a problem at all. I don't even know why we're having this conversation. Part of pre-contemplation is holding a mirror up to the discrepancies, right? I see you talking about wanting to become partner at your firm, but I also see you really struggling on Mondays after a long weekend. I see you wanting to do X, Y, and Z, but I see you missing important meetings with clients because why? Because it's easier to smoke marijuana, because somebody else can do it. So like pointing out discrepancies, I think is another way that really helps move people from pre-contemplative into like, well, maybe this is something I should think about, right? Because that's a step further than, no, this is your problem, Mom. This isn't a me problem, So just some things that come to mind for what it's worth.
That's super helpful. Thank you.
Yeah, you're welcome.
And the presentation was just, I'm like, too fast.
Sorry.
So good. Thank you.
Yeah, we went back and forth with like, should I take some of it out? And I was like, no, I'm just going to leave it in there just to leave you have it as like a reference.
Yeah, thank you.
Yeah, you're welcome. Other thoughts, reactions?
Oh, Val has a hand up.
Hi. Where does my son been in pre-contemplation for a good 4 years now. He holds right on to his cannabis use as his way of getting through the day. That's how he uses it. It's like his best friend. As far as backing off from, and he doesn't want to get any sort of treatment because he doesn't have a problem. So any help that's out there, he's not taking advantage of. He is working, but it's a struggle. And I see exactly what you're saying about holding a mirror to the discrepancies. I'll continue to do that because, you know, he may think he's operating really well, but, you know, he's forgetting things and sleeping too much and all of that. So it's really not doing well. He's just getting by. So it's a poor quality of life, and the trajectory doesn't look too good. Where does alternative medication stand in terms of getting them, you know, to help them along if the psychological interviewing can't accomplish it? Sort of like, well, what's something that they could try? And my son doesn't want to try even like antidepressants or anything, because he believes there's worse side effects with those things. And I tend to agree as well. So I feel like I'm in this like stuck point where he doesn't feel there's any other alternatives. He's just stuck and not ready. And as far as I'm concerned, this could keep going on and on and on. So I'm not sure if this is more of a just sharing with you or just trying to think of, you know, how to get the pre-contemplation to tilt more into contemplation without forcing, because I've done the forcing route a lot.
Yeah, has there ever been a time where the forcing route has worked, Val?
When I say forcing, I tried to do like an eviction thing, saying, I don't like seeing you in my home like this. You know, for me, it's my boundary. And he almost chose to live on the street for a little bit, but I backed off and I, you know, didn't have him move out or anything. I just kind of stopped. And he's working now. So, you know, I didn't really force it too much, but I know that I may want to get back to that space at some point. You know, sometimes I just don't know what my next steps really are, you know, because it's not something, it all goes back to, it's not a drug that he's going to, you know, he's like, no one's dying from this, you know, and I think it's just this normal perception that it's not that bad, you know. It's being legalized. Like, you know, parents are just stuck thinking that, you know, they're just up against a wall because society's normalizing it.
Yeah, no, that's fair. And it's funny because I want to say 20 years ago, it was normalized because it just like wasn't that bad, right? 20, 30 years ago, like it wasn't that potent and it wasn't that bad. And the justifications around it are very similar. The language is a little bit different, but the justifications are very, very similar. I'm curious, Val, when you say like, and maybe I'll get back to that point where I'll feel like I need to say, like, here's my boundary, here's what I can and can't have in my home. I wonder for you, what do you think it would take for you to get there again?
I know for sure, if he were to fail at this job he now has, he was out of work. He's almost 20, he's 19. He was out of work for 9 months. So that's what prompted me to say, you know, get into treatment or you need to leave. And then I backed off and he was able to get the job. And now he's back in a job. So if he were to self-sabotage and not be able to maintain this job, I'll probably be going back to, you need treatment or we need to have you leave. So I think I answered my own question. I think I answered my own question. That I think that's the only option to like kind of force some sort of a treatment, because it's that important to me that I don't live with this deteriorating person in my household, because he really is deteriorating. I see the effects. He's really just in the grips of it. The family life is, you know, non-existent. He's moody. It's everything you listed there. And it's only going to get worse from what people tell me. So I'd rather be looked at as the bad guy than to, you know, just say, this is just his medication for the rest of his life, you know? And that's how he treats it. And a lot of people say that this is their medicine. You know, that's why there's dispensaries, you know, that's why everything exists like this. So it's really challenging, and it's hitting our youth like crazy.
It's so true. So one, I really appreciate you saying all that out loud, because I can almost guarantee that several pieces of that, a lot of people on this phone on this call can relate to. So I appreciate the courage it takes for that. Going back to the first thing you had said, I'll have to say this. I don't have a medical background, but I can say that there's, and you had said that he's not in a position to want to use medication, but if he were, Wellbutrin actually has been found to be pretty helpful. It's not on label when it comes to marijuana craving and use, but I just kind of put that one in the back of your head. I think the other thing is, again, no one's in your shoes, right? We're not living your life. One of the things to consider is, I think sometimes we, as family members, we draw this line in the sand and we say, don't cross this line. And then they cross the line and you're like, okay, now this line, don't cross this line, right? And we keep moving with them. And we're like, excuse my language, well, shit, what happened to the line back there, right? And we lose sight of it. And I think that's part of the reason why when we talk about values, I would really encourage you to take a look at some of the values pieces, because I can say that when I have active addiction in my home, everything about me changes,
Absolutely.
right?
Yeah.
And I, from a value standpoint, I end up in a position where I start to reset and re-acknowledge my values. When I go to Al-Anon, when I hang out on calls like this, like that's when I start to think like, oh, I can see how I've compromised my value there, right? And here are the pieces that I really want to be in place. I think thinking about that and thinking about not boundaries to change him, but boundaries to hold space for you and your home. Think like if we change that lens, I think so many times we think of like, if I set this boundary, then you will do X. And really think about, well, if I set this boundary, then I'm going to feel X, right? And so when we talk about that demonstration, that's, I'm going to need to continue to move on with my life, and I'm going to demonstrate it. My train's going to leave the station, and I'm going to make the train look really appealing, because I'm going to be happy, and I'm going to take care of myself, and I'm going to be honest about how I feel. And we have to think about, they're not on our track. They're on their own track. Hopefully they're going in the same direction. But part of the courage of being a family member is, can I start my train on the track, not knowing whether or not your train is going to pull out of the station? And as family members, like, that's the fear. What if I get better and you don't? And the truth is, if both of you are in the station, no one moves anywhere. And you're already starting out of the station because you're on this call. So I think that, in conjunction with, when we talked about contingency management, he's in a position where you've said like, hey, if you can't keep a job, you can't be here, right? Like that's something like, this needs to be a part of being a productive member of the household.
That's exactly
so
right.
A piece of contingency, and a piece of contingency management is celebrating that. What I love about DBT is, it's not this or that, it's both, right? I can be really proud of you for getting up and going to your job that you're holding, and also really hold space in my household that like that mood can't be in our common area. Like both things can be true, but I think sometimes we don't always celebrate the progress that's being made, because we're like, but you're not doing this too. But but you're not in a good relationship, or you're not doing the dishes, or you're making a mess. Like it's okay to hold space for both.
Absolutely. I'm in a DBT workshop as we speak. So it's brilliant. So thank you so much, because it's all gelling together, and I think I'm on the right track. So thank you for confirming that.
Absolutely. DBT is wonderful. I love it. I'm so glad you're doing it.
Thank you. Sorry I took up
You're
that much
welcome.
time.
Are you okay staying on for a few more minutes, Kate? We
I
have
am.
we have some parents that usually they let a few other people ask questions first, and then they jump in and I know they're there.
I'm here.
Okay, good.
Hi, Kate. My name is Anita. My son has never touched marijuana except for tried a gummy, but he is addicted to alcohol, and I'd say he's pretty addicted to benzos. He's got a prescription of Klonopin. He's abused it in the past with the alcohol. So I noticed with that, there's always an increase in the dose. And it's almost like where he's at the point, he feels like he can't live without it. People have said in the past, oh, well, what about, he's got very severe anxiety, just almost non-functioning. But people have said, oh, what about a medical marijuana card? So is that different? I look at Klonopin. Also, I think of that as a terrible drug because I see what it does to him when he's not taking it. And then when he comes off, when he doesn't, because we distribute it to him and he doesn't get it, he gets it throughout the day. But when it's wearing off, he's constantly drinking. It's just like a vicious cycle. But yeah. Do you think the potency of a medical marijuana card is the same as what it was 20 years ago? I don't know much about it. Or is that just going down another big, terrible, thing that he's going to get hooked on? He's actually very afraid of marijuana, believe it or not. Nothing else, but, so we haven't gone, I won't, I don't want to get him hooked on another drug, but I just wanted to get your opinion on that.
Yeah, so I have a lot of thoughts. So one, it makes sense that if he's struggling with Klonopin, he's struggling with alcohol and vice versa. People will talk about, a lot of times we refer to benzodiazepines as like freeze-dried alcohol because they go into the same exact receptors in the brain. Right. There's this cross tolerance, right? Mm-hmm. So in looking at that piece, it all makes sense. I do want to say out loud that just coming off of Klonopin cold turkey is a really bad idea. If you've not heard that before, I just had to say that out loud.
Oh yeah, we've seen him have a reaction to.
Yeah, and there's a high risk for seizures coming off of benzodiazepines if you're using them in higher doses and you just stop. So just as a treatment provider, I would say that out loud. But here's the thing: if you're using, again, the problem isn't Klonopin, the problem isn't alcohol. The problem is what happens to us when the chemicals go in, when we use them addictively because they have addictive properties to them, right? So if he is using things like alcohol and Klonopin, both of which are mood and mind altering, to change his state, which his state is anxiety, switching over to marijuana, it's just one other thing, right? It's instead of two people dancing, it's just adding a third person into the dance, really. Right. So it doesn't sound like that's the solution. And research doesn't show that marijuana actually makes anxiety any better anyway. The other thing that happens with Klonopin is there's rebound anxiety that comes with Klonopin, right, which is what you're talking about, right? Yeah. So I start taking Klonopin to reduce my anxiety, but the anxiety of actually reducing or coming off the Klonopin is sometimes 5 times worse than my anxiety when I first started. Exactly. So when you look at some of those pieces, I think it's great that he's afraid of marijuana. I think that's a great thing. I also think that if there's a part, if you're in a position where you're holding his Klonopin, there has to be a piece of him that knows that it's problematic. So one of the questions that I would have is, maybe not a question, a curiosity of the provider who's providing him Klonopin, do they understand the dynamic? And like, I would be curious about the story there.
The doctor does know, Ryan, he knows that he's drinking his, liquid, what does he call it? Liquid anxiety or whatever by drinking alcohol, depression. Ryan always tells him I'm more depressed and more depressed. And we're at a point where he's not increasing the dose anymore because, I mean, he's landed in the hospital a few times from abusing the Klonopin with the alcohol, or coming off of it. But he was okay with, and a few people were okay with adding another, he's on, I guess not a huge dose, but it has been increasing slowly because you become immune to it. So I'd say every 6 months or so, he's going up 0.5 milligram, I think it is. And that was like, okay, well, you stop drinking, you can have that extra 0.5 dose of Klonopin. And that's what they were sort of doing. But you're kind of maybe feeding one over another.
Right. Right. And I think so. I think it could be easy to think about it as, is the marijuana as bad as the alcohol or the benzodiazepines? And one of the things that happens with marijuana is you don't go to a doctor and they say, here's, the prescription and the dosage. A lot of the dosage details come from when you go to the dispensary. So then you're in a dispensary with people that don't really have a medical background like an MD,
Right.
that's saying like, okay, here's the dosage that I'm going to give to you based on all of this knowledge. You're going to a dispensary and it's almost like, going to a convenience store and saying, I'll take this dosage instead of this dosage, and I'll take it in rolled cigarette form versus prepackaged cigarette form.
Right.
So there's not a whole lot of, when you look at those pieces, it doesn't fully make sense when you look at it from a medical standpoint, because that when you take Klonopin, that it's 1 milligram.
Mhm.
And that pill has 1 milligram, just like the next one does. It's not the same when it comes to marijuana. So it's one of those pieces that, here's what I can tell you. In treatment, the people who are using marijuana to reduce their anxiety, we only focus on coping skills for anxiety because the anxiety of even coming off of the marijuana is significant. So it's basically, it ends up being replacement. So then the question is, what are some of the other ways that if he's using alcohol and benzodiazepines for relief and it's not working, what are some of the other skills that are put into place? And back to, who was it? It was I think it was Val who asked who was speaking before. And one of the things she had talked about was like, yeah, he's working, and now what? Super proud of you for holding the job, and super proud of you for talking through this and being willing to, have me hold your Klonopin prescription. And that's not normal, right? So what are for you to be here or for us to continue to move in the right direction? I need you to interview 2 or 3 different therapists and pick which one you're going to work with. I need you to go to this DBT workshop for the next 8 weeks so you can work on skills. Like, what are those measurable things that if you're struggling with anxiety and the pill is the coping skill, you're not going to just take the pill out without replacing a coping skill.
Right.
So like thinking about what are some of those other skills that might be beneficial. Inpatient treatment helps with that. Outpatient treatment can help with that. But like thinking about some of those pieces, like how do you leverage that shift?
Right.
I don't know if that's helpful or not, but
It's very helpful. Yeah, thank you. I've been wanting to get him to do like maybe a DBT workshop, and I just got to get him on board with wanting to help himself. But no, that's very helpful. And you're right, like he's got to replace it with something that he can learn coping skills with.
Yeah. And he deserves to have less anxiety without being dependent on something on the outside, giving him relief.
Right.
That's like, it's like slavery,
Mm-hmm.
Like if you think about it, that's hard. Yeah. And maybe that's the piece that like you deserve to feel better, and you deserve to be able to have the skills to feel better on your own without all the side effects of all this other stuff. Like you deserve better than that.
Right.
You know?
Yeah. Thank you so much.
Yeah, you're welcome.
Is there any other burning question before we end the session? I see a few others that might have A question. Ingrid, you've been pretty quiet so far. Anything you want to ask?
No, I was just interested when you were talking about, I'm in the field of, I do prevention. And so I learned a lot from from your presentation, which was excellent. And then I was looking at the risk and protective factors and the dose. And I do a lot with parents. And I guess I was just wondering, in your experience when you're doing presentations with parents where their kids are not using, or they may be, using, are there certain things that have really resonated with the kids? Because I do find there's so much with the legalization. I do feel like we're on an uphill.
Yeah, no, that's a really good question. So yes, so some of the things that I think resonate, let me think about that for a second. Okay, so if you think about kind of stages of development, your adolescent and young adults, one of the pieces that we talk about so frequently is that friend groups are the most important people in their lives. We minimize that parents are also still one of the most important peoples in their lives. So here's the thing, I have lived through the teen years of my 20-year-old, and I'm just getting ready with my 13-year-old, and my 13-year-old, like, it looks like I'm not that important. But the truth is, when you think about 13, 14, 15, 16, you are incredibly important to them, even if they don't show it. Even if they don't show it. So I think one of the things that resonates is for parents is, even if you feel like they're not listening, they are. Best conversations I have with my kids is when we're in a car and they're not looking directly at me, right? Because there's not that, like, going one-on-one with adolescents, as you guys know, can be really hard, and it can be intimidating for them. No matter who you are, it can be intimidating for them. So I find that my 20-year-old, it's like a cup of coffee in a car, like best conversations I can have with him. The other piece is they are a lot smarter than we think they are, and they have a lot more experiences than we wish they did. So my husband, God bless him, is a high school health teacher. He teaches kids about sex and drugs and relationships. I can't do what he does. One of the things that he talks about is that if you think your 13 or 14-year-old don't know X, Y, and Z, your 11-year-olds do.
Yeah.
So I think a piece of it is, as parents, sometimes we wait too long to have the hard conversations because we believe that they won't understand. But if we don't fill in the gap with appropriate information, they're fine. The internet's teaching them the information rather than you. Their friends are teaching them the information rather than you. So when I think about what's impactful, I think sometimes as parents, I know this sounds crazy, but we almost feel intimidated, like they're not going to listen, or they're not going to, it's going to impact my relationship. It's better to have the conversation. And I don't have it in long periods of time. I put like snippets out there, and it's not just about drugs, but like snippets about sex and protective sex, and about relationships, and about alcohol, and about, how to nurse a beer at a party instead of letting other people mix you liquor drinks. That's a bad idea. Figure out how to nurse a beer, right? But like having those conversations in like small snippets, I think, like, empowering parents that you have more power than you think you do, even if it looks like you don't. I think those are the things that, like, when I talk to parents of, when I think about parenting, when I talk to friends' parents, and I think about the parents that I've worked with over the years at Karen, I would say those are the initial things that come to mind. Like, we as parents are actually more powerful than we think we are.
Okay. Thank you. And I just want to say thanks to the parents that shared, because it really helps. I talk to parents an awful lot, and what you share and just sort of understanding what's going on helps me understand better. So thank you. Thanks, Paul, for the invite. I appreciate it.
Sure. And Heather, you'll be the last question this evening, but please go ahead.
Hi, Kate. Great presentation. Really amazing. I have a question for you because you brought up Wellbutrin. So, are there any other sort of harm reduction treatments that are being used, like naltrexone sometimes has been off label for marijuana use disorder or cannabis use disorder? But I just wanted to know what those alternative treatments are that help. My son's already on antidepressants and anti-anxiety medication and has had a CUD for probably 5 years. And, he's been in rehab and I've done interventions. None of it's really worked. And so, and I have a psychiatrist, whatever. Anyway, I know there are some things that can help with the process of getting off cannabis, or at least helping with symptoms or stop cravings. And, I know naltrexone is sometimes used. I don't know if you guys use that at Karen. It's used mostly for alcohol, and opioids, but I think it does have some beneficial effects, but I don't know. And
Yeah.
I was just interested because you brought up Wellbutrin, which, I have a daughter on Wellbutrin and I have a son on Zoloft, and Wellbutrin has been, it seems like a different acting drug in a lot of ways. And I was just interested that you brought that up as something that's being used off label for CUD.
Yes. So, Wellbutrin can be helpful with cravings. Actually, similar to, it works in a different capacity, but similar to, thank you for bringing up naltrexone. So Karen uses naltrexone typically for, as you had said, alcohol use disorder and opioid use disorder. Now, naltrexone is the pill form that you take on a daily basis. But if you want something on board for a month, you'd look at Vivitrol. It's a Vivitrol shot that you take once a month, and it is naltrexone. It's just not if I wanted to drink or use, I would stop taking my naltrexone. If I have a craving and I want to drink or use, and I already have Vivitrol on board, I'm not going to get the same effect. So I may think twice about doing it. And yes, I have heard of naltrexone being used for severe cannabis use disorder. What I'd like to do is, I was with Dr. Sholey earlier today. He's our medical director. Let me get in touch with him. And if I can let Paul know a little bit of information about some other medications, he can get that to you, because I don't know off the top of my head. And I know that there are. I know that we've more recently been talking about Wellbutrin and actually also naltrexone, now that you say it. But I know there's one or two other medications out there. I just can't recall what they are, but I can look into that for you, Heather.
Thank you. I really appreciate it.
Yeah, absolutely.
Yeah. And he, by the way, my son goes through severe withdrawal when he goes 24 hours without smoking pot. Like, he is really sick. So I think, from my perspective, I don't look at marijuana as any different than any other drug, because it's pretty much, ruined his life on some level. But he gets really, really sick. I mean, he is really sick when he does not use marijuana. And so when people say it's not addictive, it's kind of like, I don't really know what they're talking about. You know what I mean? So
I went toe to toe with a patient about 6 months ago. Not toe to toe, that sounds really bad. But I was in Chit Chat Auditorium. We had like 85 patients in there. And I was talking about, marijuana, and like it sits in the fat cells. And like, when do you think you go through withdrawal from marijuana? Well, it's typically like 30 days out, right? Like, it gets worse 30 days out when you're leaving treatment. And this guy was like, marijuana withdrawal isn't a thing. I was like, whoa, wait a minute. Wait a minute. It totally is. So I just, I'm sorry. And I appreciate the validity of that. So.
No, it's very, very real. Anyway, thank you, Kate. Thank you, Paul.
You're welcome, Heather. I'll get that information to Paul and loop back around with you.
Sure. Thank you very much.
Can I ask you one more question?
Sure.
So sorry, I came on a little bit late, but I'll keep it brief. But could you talk a little bit about, so what my husband's doing, he has a lot of marijuana. He says he's going to quit alcohol, but now what he's doing is microdosing on mushrooms. I wonder if you could talk a little bit about that with people now microdosing, like with their depression and their anxiety.
Yeah, so psilocybin, yes. So what can I say about that? What I can say about that is there's some people that are looking at the use of that chemical in conjunction with therapies. There's this like idea that it actually makes therapy more effective. Research doesn't back it yet. It's a curious question. But if you look at any of it, right? If I struggle with addiction, it's not about the substance, right? The substance is the thing in the seat. And if I struggle with addiction, if the substance comes out of the seat, I'm going to put something else in it, right? So part of my background is process addiction. If I have all of the symptoms of addiction, I'm looking outside of myself to make myself feel better. I'll continue to do things despite consequences. I struggle interpersonally. I can't manage my own affect. I struggle being just living in my own skin. If I put down alcohol, I'm going to pick up pot. And if I put down pot, I'm going to pick up shrooms. And if I put down shrooms, maybe I'll pick up work, or maybe I'll pick up food, or maybe I'll pick up sugar, maybe I'll pick up sex. I'll pick up something else. So what I would say is if he has symptoms of addiction, when you pick up chemicals that have the capacity to be mood and mind altering, is there a problem with shrooms? I don't know. Is there a problem with cannabis? I don't know. There's a problem when you are struggling with addiction and use those chemicals because you use them addictively. So I don't know if that's helpful or not, but I've been a relapse therapist for a really long time. If you don't address the stuff, if you don't address the why, you're just going to keep picking up different things and putting something in the seat. Because the idea of leaving the seat empty and looking at some of the other things is really challenging. So I would say if he's abusing alcohol and he's abusing cannabis, I don't know that shrooms would be any different. That's just my 2 cents.